Test 1, 2, 3, 4, 1, 2, 3, 4, 1, 2, 3, 4.
It's on. It's on. You tell me when to start? Yep. So good afternoon. Obviously, please feel free to keep having your lunch, and I'll be talking about discussing current and emerging non-invasive respiratory support strategies, specifically CPAP, but also the other ones. I'm a neonatologist, so I'm sure you don't practice neonatology, but that's okay, because the topic that I'm going to talk about is actually quite pertinent for almost all the fields in medicine. In adult medicine, there's a lot of effort also in non-invasive respiratory support, and there's an increased use of CPAP also specifically. But I'll also be talking about how to reduce lung injury. This is very pertinent. So I would say this is pertinent for each of you, because you may one day finish in an ICU, and the ventilatory strategies that are used can make the difference between life and death. The major study that I can quote is the New England Journal of Medicine paper on permissive hypercapnia in adult patients, in which mortality was decreased from 40% to 31%, just by how you use the ventilator. And so this is what we'll be talking about today. I have no financial disclosures, no conflicts of interest to discuss. So this is the outline, and I'll give you some background first. There's evidence that invasive ventilation increases the risk of lung injury. So there's a lot of evidence from animals and human studies that the ventilator itself causes lung damage. And there's evidence that this injury is mostly mediated through VOLUTRAUMA. You may have heard the term previously used, barotrauma. Baro is for pressure. But now the concept is VOLUTRAUMA. It's how much volume we use to distend the lungs that causes lung injury. Thus, non-invasive low tidal volume strategies that maintain lung volume at end expiration, such as CPAP, may reduce lung injury. This is a schematic scalar signal of a volume. That's volume on the going up and down. And you can see the zones of VOLUTRAUMA. They can be during inspiration, like over distension of the lungs, or they can be at end expiration from VOLUTRAUMA, and that's being called atelectotrauma. It's a trauma that occurs during atelectasis. So during that period, the lung volume gets so low that the alveoli collapse. So what we're trying to do is use the right amount of tidal volume and the right range of lung inflation. So these are evidence from a lot of studies that have been done to determine whether it's VOLUTRAUMA or barotrauma. And you can see here, the IPPV was used in this case with high volumes and high pressures, and you see 5 measures of lung injury. Then the iron lung, remember from pictures, iron lung from inflating the lungs from the outside, that actually can use a high tidal volume, even though the pressure is low. In fact, it's subatmospheric, it's negative pressure. And you can see how these measures of lung injury also occur. In contrast, strapping of the lung, and this was first done actually in Mobile, Alabama, at USA University there. They strapped the lungs of rabbits and used very high pressures but low tidal volumes, because the chest was strapped, and that did not result in lung injury. And like this, there's been a lot of convincing evidence in many other studies, including human studies, in which they show that it's really VOLUTRAUMA that causes lung injury. I'll just say a few words about adult strategies. The randomized controlled trial in adult patients was done with 6 cc's per kilo versus 12 cc's per kilo. And 6 cc's per kilo resulted in decreased mortality. So I think it's something quite important to know. So let's see how we can prevent VOLUTRAUMA. We can use low tidal volume, but that results in decreased CO2 elimination. And that leads to hypercapnia. You can increase the ventilator rate, but it's not always efficient. And because of the time constant of the respiratory system, you cannot go to very high rates on the ventilator. So the result is hypercapnia, which you can actually turn around and tolerate hypercapnia. We call that permissive hypercapnia. And a way to think of it, to visualize it, is here we have some beakers here. The first one is says 40. So that's a CO2 of 40 in the alveoli. That's what we all have right now, a CO2 of 40. When the tidal volume goes in, and this is just for depiction in the figure, let's say it takes out some CO2. It mixes with it and takes out some CO2. However, if we let the CO2 rise, and this is usually done chronically, and we let it rise to 80, for example, just to make the numbers simple here, when we get the same tidal volume, it removes twice the amount of CO2. So this is part of what people are trying to do now, clinicians are trying to do now. They're tolerating hypercapnia and using smaller tidal volumes to remove a lot of CO2 because the CO2 is higher in the body. You can do this mathematically, actually, and these are actually calculations for a baby with a certain amount of the respiratory disease. And you can see here that if you maintain a CO2 of 30, if your goal is to keep the CO2 of 30, you have to give 400 cc's per kilo per minute. That's like twice the normal ventilation of a baby. But if you keep a CO2 at 40, you reduce it substantially. If you increase the CO2 to 50, you reduce the minute ventilation to about normal minute ventilation. So this is a strategy. And this has been tried in many animals, so I'm going just to summarize by level of evidence here: meta-analysis, randomized control trials, experiments, physiologic studies, and opinion here. And you can see the evidence in favor is the first row, and you see that most of the papers show that it's beneficial. A few papers have shown no benefits. That's always the case many times because of the small sample size. And a few papers have shown adverse consequences. These are really trivial adverse consequences. The major one is that if you allow the CO2 to rise, it may be so high that you need to give oxygen. This happens with the COPDers, as you know. They have a high CO2, and the consequence of that, in part, is that the oxygen level drops down a little bit, so you have to give them a bit of oxygen. So you're meant to laugh here. So, so this is, I don't study rats, I eat them. I work in Zambia also. I have a project in Zambia. And in Zambia, they eat rats. I tried, but I didn't dare to eat them. So I'm pretending I'm eating a rat there. But the point is that from now on, all the evidence I'm going to give you is not from rats or other animals. I study humans, and I'm going to restrict the evidence that I give you to human data. In fact, human data that has been so important, that has changed totally the recommendations for neonatal care. And similarly, I will not review the adult data, but there's similar data like this in adults recommending more non-invasive ventilation, more permissive hypercapnia. So let's go to talk about CPAP before and after ventilation. So I mean, before we intubate the patient, we try to give them the opportunity to see if they can become stable on CPAP. So I'm going to ask you and see if anyone knows which famous baby had respiratory distress syndrome or hyaline membrane disease. That's a disease typical of premature babies. Which famous baby had respiratory distress syndrome? Anyone remembers? If you were, Stevie Wonder became blind. He also had it, but he survived, and he's blind from ROP, retinopathy. Yeah. I heard someone say?
Lindbergh, what, the Lindbergh baby?
Lindbergh baby? I cannot remember. So it's President Kennedy's baby. If you recall, Patrick Kennedy was born actually 2 months before they shot President Kennedy. He was a preemie. He was born a month early, and he had immature lungs, and he died from RDS. CPAP had not been developed yet. Because of his disease, he probably would just have survived with just CPAP. What's CPAP? You'll know. Continuous positive airway pressure. What happens in premature babies, there are alveoli collapse. If you give them a constant pressure, you can keep the lungs inflated, and then they survive. So I'll show you the evidence. There was a large study in which they tried CPAP at birth in premature babies, instead of intubation with surfactant. You may know that the premature babies have surfactant deficiency. So in the 80s, surfactant was developed, and it's been given to premature babies. So in this study, they tried to see if CPAP worked as well or better than surfactant. And I've done research on this, and the mechanical properties of the lungs improve to the same extent with CPAP or with surfactant. So CPAP is really a good alternative. So they've done this study comparing CPAP and limited ventilation, which means really permissive hypercapnia, versus surfactant. And if you can see here, the idea was to keep them on CPAP until the FiO2 was 50%, and then on the other group, give them surfactant early. And these are the main results. You can see here, there's a trend for benefits in death or BPD. BPD is bronchopulmonary dysplasia. It's a disease it's a chronic pulmonary disease of premature babies. So if you see former preemies around with oxygen, that's what they have. They have BPD. And you can see that there was a trend for reduction in mortality, actually. And in fact, in the yellow here, in the 24 and 25-week infants, CPAP infants had a lower mortality compared to ventilated babies and given surfactant. This is really amazing. This effect size is large, as you can see here. It's from 32 to 24%. So it's a very large reduction in mortality by using CPAP instead of a ventilator. Other studies have been done like this, and this is a meta-analysis of those studies. So you can see the reduction from 45 to 40% of BPD or death. And so the American Academy of Pediatrics has started new recommendations, has given new recommendations to use CPAP at birth instead of intubating babies. So these have formally been published now. I just skip the details, but basically you start CPAP early and try not to intubate and give surfactant. But if the patients are getting sicker, then they get intubated and they get surfactant. Let's get to CPAP with SIMV. So when the patient is on CPAP, you can augment the respiratory support by giving them, for example, BiPAP. I think most of you know it as BiPAP. Is that right? Or synchronized. SIMV is called synchronized intermittent mandatory ventilation. Very similar to BiPAP. It's basically the same thing. So you give them some support, non-invasive support, and try to inflate the lungs. So non-invasive ventilation with SIMV, for example, increases minute ventilation and stimulates the upper airway, decreases central apnea, splints the upper airway and reduces obstructive apnea, recruits the lung volume and decreases the anatomical dead space. This actually is going to be quite important in many other non-invasive modes of ventilation, that you maintain the upper way more stable, and the patient does not need any, to have an endotracheal tube. This is a meta-analysis of 8 trials of non-invasive ventilation added to CPAP. So we don't give just straight positive pressure ventilation or CPAP, continuous ventilation. We give also intermittent mandatory ventilation on top of that. And intermittent mandatory ventilation on top of CPAP have been shown to reduce extubation, meeting extubation criteria, needing reintubation, and also has resulted in reduction of air leaks or pneumothoraces. So there are many benefits of this non-invasive ventilation being used on top of CPAP. I think in adults, you use it like BiPAP is a typical level of support that is used comparable to this. So let's go to high flow nasal cannula. And this is something that has changed a lot the field in the last few years. So it's been shown that you can give flow, and that may maintain lung volume, but very importantly, it may eliminate dead space. So you blow a larger amount of flow, not the typical low flow for COPD, but the higher flow that supports ventilation. It supports ventilation by forcing gas through the lungs a little bit, more specifically eliminates the dead space that is proximal, so above the larynx. High flow can be so effective that in animal studies, they can put an endotracheal tube down in, and they can blow so much gas that the animal becomes totally apneic. The CO2 goes way, way down just by blowing gas into the trachea. That's actually called tracheal gas insufflation. So you put a tube in the trachea and blow a lot of gas. You have to have a system that allows air to come back also. So you blow the air or oxygen mixture, and you blow it in, and out comes CO2. So much CO2 that the animals, the CO2 goes down and they become apneic. Or you can paralyze them and they maintain normal blood gases. So, but what we're talking about in terms of high flow cannula is to give the flow proximally. So it's not in the trachea, it's proximally, but because the mouth is open, it can eliminate the dead space around the mouth. So high flow nasal cannula has been compared to CPAP for early respiratory support. This is a multi-center randomized trial in Australia. It's conducted on the moderate preterm babies, not the extremely preterm. The slide I showed you before was extremely preterm infants. These are moderate preterm infants, and they compare high flow cannula to CPAP. As you can see here, these are moderate preterm babies. The gestational is 32 weeks. Term is 40 weeks, so this is like 7-month babies on average. And you can see here that the treatment failure was worse actually with high flow nasal cannula, supporting again the use of CPAP better than high flow cannula. So in these studies, and there have been multiple studies, I'll just show the biggest one. In these studies, high flow nasal cannula have been shown to be maybe comparable, but usually inferior. In which babies could it be comparable? The more mature babies, then it becomes more comparable. Why? In part because their alveoli don't collapse. In that case, you just need flow, and you don't need the constant pressure that CPAP provides. So in patients with normal alveoli, let's say surfactant sufficient alveoli, typically those are 37, 38, 40-week infants. In those infants, high-flow cannula works well. But in the more premature babies, continuous positive airway pressure or CPAP is generally required. There have been some other new interventions that have been developed. So one is sustained lung inflation. So because the lungs at birth do not have gas, the infant gradually breathes and over the next few hours establishes the functional residual capacity or FRC. So the lungs gradually inflate, and if you've had a baby yourself or know someone, you know about babies, you may have heard that they grunt. They go like, So they have expiratory grunting, and they're trying to establish their functional residual capacity or FRC. They're trying to inflate the lungs gradually. So a strategy that has been developed is to inflate the lungs with a big breath right at birth and see if they will do better. The results of this are a bit controversial right now, and actually there's an increased tendency of death. If you see this meta-analysis, and this symbol here shows that it favors the control group, the group that did not get. So there's a tendency for more mortality. So the lungs of babies are very susceptible to lung injury. So this big breath may not be helpful. And the final topic I want to talk about is bubble CPAP. So the usual CPAP use is provided by a ventilator, and it's a stable level of CPAP. And there's some evidence that giving CPAP with a bubble system will be more helpful. So I don't know if any of you have gone to developing countries and you in healthcare. Has anyone volunteered ever in developing countries? No. They don't have all the resources. They don't have ventilators. So one way to do it is with a bubble CPAP system. A bubble CPAP is very simple. You take your water bottle before opening, so you take clean water, and then you put a tube through it and put gas going into it, and it generates a pressure that depends on how much down the water you put the tube. So if you put it at 4 centimeters, it creates 4 centimeters of pressure. Babies usually get any pressure of 5 to 8. So it's very simple to take a water bottle, put a tube there, connect it to the baby, and connect it to an oxygen source. Actually, I've done this in a baby in Africa where they did not have ventilators, and for a water bottle there, they're like 25 cents, and the tube in maybe $1. For $1 or so, we set up a CPAP system. I'm giving all this explanation because these systems were developed in the US in the 70s, and they were first developed for babies, and now they have been used for adult patients also. There's a controversy whether they are better than the ventilator ones, and I would say the overall evidence, and I'll show it, is that they're comparable. They're not better, but they're so inexpensive. So for $1 or so, you can save a life. We have projects in Africa. You have to invite me next time so I can give you a lecture on this. But we have a project in Africa where we're trying to save lives, and it costs like less than $2 to save one life. So I'll tell you next time, so invite me. So this is, I'll just show a few studies to show that this bubble CPAP is comparable to a non-bubble CPAP. So remember, bubble CPAP is a $1 system. The non-bubble CPAP is a ventilator, $30,000, $40,000. So, and this one, in terms of CPAP failure, death, or pneumothorax, there's no difference. This one also, similar measures, BPD, pneumothorax, death or BPD, extubation failure, no difference. A crossover study showing that ventilation, total volume, and respiratory rates were the same. Another one doing transcutaneous CO2 measurements showed they're the same. So the point is, you can have very inexpensive setups that use CPAP instead of ventilators. And I show you the evidence that CPAP is better than a ventilator. And now I'm showing you the evidence that the low-cost system for CPAP works just as well as the expensive systems. So I think this is the future of medicine, trying to do a lot of things non-invasively, trying to minimize injury, trying to reduce harms. Remember that the first thing in medicine is not to do harm. So one has to always strive to reduce harmful interventions. Actually, there are 3 very large studies in neonatology that all show that for the same baseline characteristics, if you can reduce the patient acuity by, for example, using CPAP instead of a ventilator, and there are many other ways to do it, you can actually get better outcomes. So these are large cohort studies, thousands and thousands and thousands of patients. And in general, they look at what approach was taken with each patient, and each patient was classified as having a lot of invasive interventions, and the other ones classified as less interventions for the same baseline risk. And they show that those that get less interventions actually have better outcomes. So this is all quite important, not just in neonatology, but also in medicine in general. So to try to summarize, and the take-home messages is that CPAP reduces death or BPD. This is so important. It has changed the recommendations that used to happen. It used to be standard that if a premature baby had respiratory distress, had to give in surfactant right away. Now the evidence is that if you actually use CPAP instead of a ventilator, you can actually improve the outcomes on those patients. Non-invasive synchronized intermittent ventilation reduces reintubation rates and reduces air leaks. So this is a technique to supplement CPAP. This cannot be done with the $1 CPAP. That's a problem, okay? But this can be done with the ventilator CPAP. I'm talking about the $1 CPAP. I've developed a $1 incubator, and we're testing it. We're going to be testing it this coming year in Zambia. We'll see if it works. And you know, in our state, now they give a box to babies. Have you heard about the box given to babies? It's a box. It comes full of little toys and things and clothes. But actually, it's a box that is a safe place for the baby to be. So you don't put the baby on the bed with you because you roll over and kill the baby. We have always, every year, we have 5 or 10 babies that come to UAB or Children's or the hospitals in town, that the father or the mother roll in bed and kill the baby. It's actually quite common. So our state is giving, and we have a very high incidence of SIDS also by rollover. So the state that's actually giving these boxes, these are a bit more than $1, but we have developed a $1 incubator and a $2 blender also, by the way, that we're trying to use in low-income settings. I told you about the high-flow nasal cannula being comparable or inferior to CPAP. It's comparable in the bigger babies. Again, that's like a $1 cannula that you can use in a bigger term baby, and it works just as well as CPAP. I told you that sustained inflation is not recommended. And finally, a few words about bubble CPAP again, is that it's very effective as compared to the non-bubble CPAP. So now you have a $1 CPAP system that works quite as well. And I'd like to leave you with a message here. So on his deathbed, St. Vincent de Paul told the sisters, it's only because of your love alone, that the poor will forgive you for the bread you give them. That's really, it's missing a for there, but for the bread you give them. That's really interesting, no? That's sort of mind-troubling that you're giving people food and they have to forgive you. And it's not because of the food you give them, it's only because of the love you give them. So, but think of this, and I think for healthcare workers, this can be translated into something like this. It is only because of your love, because of your excellent care, because of your excellent care alone, that the sick will forgive you for the care you give them. Sometimes you take care, you do everything for the patient, and they're not satisfied, no? So, but it's how we do it, I think. It's how we provide the care that will get them satisfied and happy with the healthcare system. Thank you very much. I'll entertain any questions that you have. Comments? Do we have any respiratory people here, or nurses that work, or therapists that work with respiratory care? Do we have any people that do ventilator care? You know? Ventilator care. Yeah. But in general, I think most doctors are going now to lower total volumes, maybe like 6 per kilo. It's approach. And sometimes you have to give a bit more because the patients are too sick and they don't tolerate the low total volumes. But in general, less VOLUTRAUMA, I think that's the way to go. Well, thank you very much for the opportunity to talk with you.